to the Portside ART Relational Therapy Institute. My name is Dr. Laurie Ponsford-Hill, and today we're going to be discussing eating disorders. And with me is Christie.
Hi, I'm Christie. I'm one of the therapists here, practicing for a couple of years, and also a child youth worker.
Exactly, yes. And we've spent the last couple of years actually really working in regards to eating disorders, putting together several different workbooks.
Yes.
And so, if you come across eating disorders, which we all do,
Yes.
right? And it might not be the main reason why it is that the client is coming in, but it might be a subsidiary reason why it is that they're coming in.
It finally gets really slipped in there that there's some sort of issue with food.
Exactly.
Yeah, there's many issues involved with eating disorders, and it can verge on a scale, how bad it is, whether they're starving themselves or eating so much that they're making themselves sick, and in between in there as well.
Exactly.
So.
Yeah. And eating disorders affect all ages, all sexes, right? And so a wide range of issues within family systems as well.
Because even people think athletes could never, for example, have an eating disorder. But there's a lot of athletes trying to get like a certain calorie intake for muscle build, or they have to hit a weight class.
Exactly.
And then there's a lot of peer pressure, especially with younger kids.
Exactly.
And more now we're seeing.
For sure. And as it is that people age as well.
Wanting to look a certain way and perceived to a certain, especially when you're in that stage of dating.
Exactly.
It's a very awkward area. Trying to attract people. People tend to.
Want to look good. And then sometimes that's what happens, right? It can be a snowball effect.
And we can see overeating if they've gone through something traumatic in their lives.
Yeah, exactly.
It can be big or small depending on how it affects them.
For sure. So first we're going to be talking about anorexia nervosa. So common in Canada, up to 5% of girls having experienced an eating disorder before adulthood, right? And anorexia nervosa onset, generally speaking, is in mid-adolescence, right? And also to do with prepubescent children, right? Yes, and as well bulimia prevalence about 2% as well among adolescents. There's an increased mortality as well in children and youth, right? Morbidity in children and youth, physical health impacts as well, growth retardation, structural and functional brain changes occur, hair thinning, prepubescent delay or interruption.
They have to think of the long term.
Exactly.
Okay, so also with anorexia nervosa, we're seeing like peak bone mass reduction, cardiac complications, which can definitely be long-term consequences. And then we have the psychological impacts of depressive disorders, anxiety, or obsessive compulsive, and even personality disorders can be seen. And that's with all the brain changes. And anything medical can be long-standing, even if it is kind of taken back, depending how long it goes on for. And when it started, we can have long-term consequences when you look at like even teeth.
Oh, for sure.
Or your heart or your brain development. All that's going to be affected. And a lot of time we see like people are really focused on like how they look.
So true, image, right?
So you have to be thin, and we really see it in the media.
Oh, for sure.
And especially with social media. It's in our face all the time. We have to look a certain way, you have to be a certain body shape, and it's unrealistic. We're all very different structurally.
Exactly, yes, we are.
So it's not realistic to be like that size 0 or whatever that looks like for you, for example. And it's just that strong desire that I have to be thin.
Exactly.
I have to look this way and have this sort of hair, and it's just all kind of that fear built in. And a lot of times people fear that weight gain.
Exactly.
So then as soon as that fear starts building in, it almost gets worse at that point. Because they're like, oh, if I this few calories, then I can keep this weight, and then it's never good enough. We tend to want to go thinner.
For sure.
And we see it all the time.
Mm-hmm.
And it can get to the point where bones are starting to show.
For sure, yeah.
And there's a lack of energy.
Oh, for sure.
Who wants to get out of bed when they don't have the energy to kind of.
It's true, exactly, right? Or an avoidance
Yeah.
strategy in regards to eating,
Mm-hmm.
right? If you go to bed,
Yeah.
you're not needing to eat.
No. Or the burning of the calories.
Watching.
Okay, this many calories, how long does it take to burn?
Mm-hmm.
So that fear really builds in, and it's hard to maintain that weight loss
Mm-hmm.
because our body is constantly changing, especially as we age.
For sure.
Our metabolism is always changing.
Mm-hmm.
So we may see strict dieting and excessive exercise or self-induced vomiting, which is very common as well, and also laxative misuse,
Mm-hmm.
where they're using a diuretic to keep things clean. So we're looking at a diagnosis of bulimia nervosa. We would you normally would see 3 of these features, which are.
So significant life events bring about significant change, which is an increase in regards to anorexia nervosa or binge eating disorder, right? So significant changes like death, divorce, going away to school, as well as alcoholism or major depression, any kind of life circumstance changes, right? Especially to do with the experience of abuse, bullying, needing to fit in particular, right? And that sort of thing. Binge eating and purging also too, right? Physical health is often maintained. Symptoms are binge eating, purging, right? Complications such as electrolyte disturbances, right? Gland swelling, loss of dental enamel that you had mentioned, comorbid psychiatric disorders, mood disorders, anxiety, substance abuse, right? All go together. Adolescent functioning at a developmentally regressed level, impairing the adolescent's decision-making capabilities in regards to food consumption, impairing as well image. That's what we talked about earlier as well.
So when we're looking at family-based treatment, because really with eating disorders, it affects the family as a whole unit.
Sure does.
It's not just the individual who's experiencing it.
Right.
Because people tend to want to avoid it. We see it. It's hard to address.
So true, right? Because it's happening within the family system, right? Because when you think about eating, right, it's the family coming together, generally speaking, right? And coming together to consume food.
It is. We normally would see family meals. There's a lot of families that are moving away from that.
So true.
Where people eat in their rooms or alone. So it's almost easier to hide the eating behaviors or the non-eating behaviors as well.
Exactly.
Because no one's watching over you.
So true. And we learn our eating behaviors, right, based on our family.
Yeah, there's a lot of eating from the TV now.
Oh, so true.
Or everyone's on their phones. Whichever it is, it's very different.
It is.
So it's easier to kind of maintain, and it's easier to ignore. So when we're looking at family-based treatment, whether it's the child or even an adult that could be experiencing this, they can be seen separately, especially if we're looking at adolescents when they're dealing with an eating disorder. But we have to look at the expressed emotions. Sometimes teens want to work with their families, sometimes they can't, because their families actually could be that trigger.
Yeah, for sure.
For the eating disorder. It all depends. It's getting to know and kind of what's going to work for them. Because especially if you look at criticism from parents.
Oh, yeah.
There's a lot of comments like, stand up straight, suck in your stomach. These teens here are like, oh, are you going to eat that?
Yeah, exactly.
Do you really need that other plate?
Yeah, eat everything on your plate, right?
Yeah.
You can't leave the table until it's clear. Yeah.
We're sent messages early in childhood. And a lot of the time the parents have learned those messages from their own experiences growing up.
Oh yeah, for sure.
So it affects, and we take it in and it affects us.
Oh yeah, right.
And our responses to food. So when we're looking at criticism, especially if it's from the parents, it's better to maybe exclude them from the earlier parts. Kind of see them separately before kind of bringing together, because it could trigger the teen especially.
Traditional families, right? As well as non-intact families, right? Generally speaking, children between the ages of 12 to 18 are affected by guilt, shaming, blame, the feeling of helplessness, right?
And as we said, like, the family is seen either as problem causing or maintaining it.
Exactly.
Especially if you're looking at families that are maybe not as traditional. If it's a blended family or a divorced family and the kids going back and forth.
Exactly.
And it's just, can be a lot of different messages. And a lot of times teens will deny they have an eating disorder, especially. They're like, I'm fine. Or there's excuses that can be.
Oh yeah.
And a lot of times we see teens are hidden in their rooms anyways, or they're with their friends. So it's harder to kind of know what they're up to at that age. Because it is all about the friendships at this particular age and less of parents.
Exactly, yeah.
So it's kind of easy, and it can be seen amongst friends, eating disorders. Kind of a group thing half the time. So it can cause increasing concern over health, especially long-term consequences, the feeling of powerlessness, and even frustration within the family.
Oh, for sure.
People tend to walk on eggshells. So the family-based treatment was developed in the late 70s and early 80s. Was known as,
Maudsley method.
A stereotypical modality. So it looks at parents as our resources and empowering families from the solution-focused point.
Yeah, so family-based therapy is effective with adolescents 18 years of age and younger, right, with anorexia nervosa, bulimia nervosa, as well as reducing pediatric overweight. Family characteristics are rigidity, enmeshment or over-involvement, conflict avoidance, right? And as a child's role is a go-between in cross-generational alliances, right? Occurring alongside an emotionally vulnerable child. Yeah, so the nature of the relationships within the family provide an emotional climate in the family, right? And as well as patterns of family interactions. And the family dynamics function as the maintenance mechanisms of eating disorders and daily routines, coping and problem-solving behaviors for the illness, as well as parental engagement strategies, right? Efficacy in correcting maladaptive eating and related behaviors and blame reduction, right? It's a disease-based model promoting normal physical and psychological and psychosocial development. There's 3 phases, right? Supporting the parents, right, by creating a unified front, assuming responsibility for the child's eating in session, right? The family's main goal is to convince the child to take one more bite to achieve a minimum level of weight restoration and reduction of conflict around eating, as well as aligning with the sibling subsystem for support. Control over food consumption is then transferred back to the adolescent and psychoeducation of adolescent development.
As complicated as it can be to treat the family as a whole unit and separately and then bring them back together, there is also, it's kind of best to do a 6-month post-treatment. And that's just based on statistics and clinical research. So when we're looking, the 6-month post-treatment usually starts after like those core symptoms of bulimia or anorexia are kind of reduced.
Right.
When it's kind of getting back to the way that the parents are wanting it and the children want it. So it's usually 20 sessions or less. The family-based therapy does not target the fear of weight gain or body image disturbance. Instead, the goal is to train the parents to create that zero tolerance environment for self-starvation and also recognize those signs and symptoms of anorexia nervosa or bulimia to prevent relapse.
Right.
because that is very common, is to revert back. And it's also to encourage parents to reestablish healthy eating patterns with their adolescents, so there's just to avoid the binge eating and purging episodes that we see, and also providing that control of eating back to your adolescent when they're able to kind of make those good choices. Basically, we want to see the child healthy. And we look at family structure issues, that continue working on those, and adolescent development, psychoeducation.
All right, so adolescent focused therapy, on the other hand, right? So it basically believes that eating disorders manifest ego deficit and confuse self-control with biological needs. The key is the identification of and definition of emotions, learning to tolerate affective states rather than using starvation to manage feelings. The therapist encourages non-dieting and sets weight goals to gain weight and change behaviors. Also to take responsibility for food-related issues and learn to distinguish emotional states for bodily needs. To be able to tolerate negative affect and encourage separation and individuation. Meetings are held separately to assess parental functioning and advocate for the client.
So when we were looking at cognitive behavior therapy for the treatment, so family-based therapy was found to be a little bit more superior to adolescent-focused therapy for anorexia nervosa. And adolescent-focused therapy does offer an alternative for families that maybe don't want to participate, as we may see that, and especially for clients that prefer individual therapy. They may not be ready for that family dynamic yet.
Exactly.
So cognitive behavior therapy is the main treatment for bulimia nervosa. The cognitive focuses on the core psychopathology of the over-evaluation of shape and weight. And enhanced CBT is used to treat adults with eating disorders, and it's been adapted for younger patients as well, because it addresses perfectionism, that low self-esteem, and interpersonal concerns as well. So with CBT, it looks to engage the client jointly with the therapist to create formulations and encourage the clients to be more aware of in the moment and their own self-monitoring as well. So there may be collaborative weekly weighing, regular eating to provide structure, and educational concerns over evaluation of shape and weight, and problems linked to that self-evaluation. And also curbing repeated body checking, whether that's through mirrors or a scale or actually measuring themselves, we'll see. Reassessing feeling fat with other feelings, and proactive problem solving.